Just taking them all.
Okay, I'm sorry for the slight interruption. How do we stand with Fly Creek?
Fly Creek. We table it pending controlled substances.
No, you have to grant them a provisional.
We have to grant them provisional ALS status. Or excuse me, the REMAC has to grant them provisional ALS status. Otherwise, they can't put in for their controlled substance license.
That's what he meant to say.
Okay.
All right. Having done that,
Okay.
we have a block of medical directors proposed for a variety
We
of
have just an
actions.
informational note here about GAVAC. They're applying to the Department of Health to provide transfusion services. And send us a letter to that effect, and I just wanted everybody to be fully aware, as they did.
Okay. Informational. Then we have 4 agencies with new medical directors. Dr. Luz, Dr. Rana Rasinga from Fox. He's actually the director of Fox. And Dr. Markowitz. Any comments?
I have all the paperwork. It is certainly complete and signed off by the respective physicians. Did I spell Dr. Rasinga's name correctly? I was not sure exactly of the spelling.
I can correct you in 2 seconds.
RANASINGHB.
Right, that's it.
All right, N.A.
Yeah.
Rana Singh. Okay. I apologize. We've been corrected.
Okay. Esperance Rescue Squad seeking to push Narcan.
Right, their paperwork is fully signed off.
Okay.
Dr. Luz is their medical director.
I thought they added to the water already, Narcan. Fluoride and Narcan, it's in the water. All right, Cherry Valley, returning to BLS informational. Any background on that anybody wants to share?
They just ran out of, they ran out of ALS personnel. They truly have no more ALS personnel to provide. And they're a service that has provided exemplary intervention at the ALS level for many years, and it's regrettable they're just not able to do it anymore.
So what happens with their operating certificate? Does it get assigned to a different squad, or how does that work?
Well, no, it just gets noted that they're providing a BLS service now, that's all.
Oh, okay.
They've notified the state.
All right.
The state-
And their ALS coverage comes now from where?
their ALS coverage?
Yeah.
I honestly do not know that.
CMT.
Oh, is you folks? Okay.
Yeah, out of Cooperstown. And Worcester, depending on where, yeah. But Worcester sometimes is a lot closer depending on the district.
We've ordered them, correct.
All right. There has, when the Department of Health was here, we talked about the demise of a lot of squads statewide, right?
I was just at a meeting on Monday, which I'm going to get a report on this afternoon. One of the squads up our way is losing their very last EMT. The certification expires on the 31st of October, and they're getting arrangements made with a neighboring paid service in Perkins County to provide service for them, which will allow them to keep their operating certificate. But the situation is not going to get any better, I fear.
Next up, Stamford, ceasing operation.
On April the 1st, they've advised everyone in a very timely manner. They advised us last June, as a matter of fact, but I just want to repeat it here for the record so everybody's fully aware. I don't know what their situation is going to be there either.
We're talking about doing a first response agency.
Is that right?
We still have works on.
Mm-hmm.
right, well, it's a good thing we're a healthy upstate population. We don't really need, immediate ALS.
It's a good thing we never fall ill when we get sick. Right.
All right, Mr. Farrell, you're up. BOSFR. You can translate.
AAREMS gets a gold star, everybody's compliant.
That's it?
Lions?
Gold star? Okay. And then DOH certification inspection requests, anything?
Same thing, gold star.
Okay. Let it be noted. Mary, you want to update on controlled substance licensing?
The only one we are waiting from this region, Joe, is Walton, correct?
Yeah, it's in for review now.
No, it'll probably get sent over to B&E tomorrow.
What's the usual turnaround time once every little paperwork's together?
The official answer is 45 days. Truthfully, it's anywhere between 2 days and 2 weeks.
Oh, really? It's pretty fast.
It is a relatively quick process.
That's good.
The only other one that'll be an outlier now will be Fly Creek is the only one. Now that you've just granted them provisional ALS.
Right. All right, REMAC RSI QI review. This pretty much speaks to like the GAVAC report, right?
Right. Well, you had, if you remember, a couple of weeks ago, Gus, you asked me about what's the chances of using the state bridge to do a little informational QI for the REMAC physicians on RSI in the region. So I sent you some preliminary information, and then Peter Brody from the Department of Health was very kind to put together a very detailed report, which I had intended to print out yesterday and bring for the REMAC physicians today, which goes in great detail with all the RSI interventions in this region this year so far. Unfortunately, the report writer function on the state bridge was a little bit disabled yesterday afternoon. I couldn't print it out, but I will get it together, and I will see that the REMAC physicians get a copy of it just for preliminary discussion purposes.
Okay, yeah, because we've been discussing it a bit lately with in a couple different contexts, so it's good to look back at our own performance. So the tool you got from this gentleman was the QI tool itself, and then you just put our data into it. Is that what
Right.
you did?
He put it together. He put it together tailor-made for AAREMS. He did a very nice, very thorough job on it, and it does everything really except go down to the individual PCR with name, date, place, because even the state doesn't have access to that information. It's the HIPAA thing. They deliberately block themselves, much less us. But it goes right to. On the afternoon of June 17th, there was an 81-year-old male, and this is what happened, that sort of thing. It doesn't go into names and dates, but dates it goes into, but not names and addresses and such like. But anyway, as soon as the report writer function is up and running again, I will crank that out.
Okay. And Joyce circulated a draft RSI, what do we call a regional policy and educational module, right?
Right. I gave one to Gus, and I have for the other doctors here. I have a flash drive with our present draft that Joyce has put together using the Monroe-Livingston paperwork, also the GAVAC and the REMO paperwork, and she's put together a very thorough 25-page document for review. She's also actively soliciting feedback, by the way, and I'm very sorry that she can't be here today. And of course, she's very sorry also. She has a little medical issue which came up yesterday afternoon, which will preclude her traveling for a day or two. But in any event, she said that she would like a little feedback. I sent this out as an email attachment, but I also brought it for the physicians, just so sort of a belt and suspenders thing. And she would very much like feedback, as I said. But, and then we'll have a draft document that everybody can take a look at the next meeting.
All right.
And the REMAC docs can look at it.
Yeah, we would need feedback on that from the group.
From the training committee and from everyone, really.
Anybody's impacted by it.
Yeah. And,
It really restricts it quite a bit. I mean, it's restricted to agencies that do a lot.
Right.
So there might be some feedback about,
As regards as the activity of the agency that's applying for RSI, what she put down in the draft was at least 1,000 calls a year. She got that from one of the documents that she was dealing with. I can't tell you
I
which
think
one.
that was quite a few of the RSA documents,
Was
was
it
1,000
really?
calls a year.
Yeah.
Okay.
The only thing that, I really noticed is that it puts a lot on the region itself, on you and Joyce, what this plant does. You have to monitor all these medics, and you have to make sure that the education's happening, and I understand yours.
Even the
yours-
QI plan.
Yeah.
There's a regional QI plan in here, but I don't know of a regional QI program anymore. We used to have it, and it's kind of not happening, and certainly with EPCRs, that component has gone away for all of the big agencies at the regional level.
I can get totals for all the agencies that via the PCR route, but as far as individual PCRs, I don't have access to those except by asking the agency itself.
But, no, you have, the state bridge allows you to pull all of that document, enough that we can operate and perform a QI.
Oh, yes.
The problem is there is no regional QI committee. So who's going to review that at the regional level?
Probably time for us to consider such right now. Well, I say now, not this instant, but
Yeah,
But it's also the manpower's gonna take to credential each one of these paramedics and do the thorough background check and then make sure they're keeping up on their 6 months. And then this also talks about specific education that has to be done at the regional level. It seems like a lot for a staff of.
how is that handled? I don't know the answer to this. How is that handled in Remo, for example?
Dean's here.
The individual agencies.
Dean's here, ask him.
Ask him.
So specifically, you're talking about the credentialing of
When did you come in?
MFI credentialed medics is what you're specifically
Correct.
speaking to, right?
Right.
So we handle that at an agency level. The agency is responsible, the medical director is responsible to make sure that that is happening at the agency. We can do and pull a report, and we can pull some data from the state bridge. Oh my God. Which is limited. The data is limited on the state bridge. However, we have to trust that it's the medical director is licensed, so it's under their responsibility to make sure that it is handled and maintained.
Internally, you guys are handling it?
Oh, we were continuing that alone. I mean, we do continuing, every 6 months, every one of our medics has to sit through a class and perform black and white testing, that's practical. It's, yeah, I mean,
And it says that your medical control position has to be there some part, like in this plan, it says that they have to be there, be some part. It says the regional medical director has to be there, be some part.
yeah,
I
you
think
won't want
that's
the
a
regional,
lot.
yeah, you won't want the regional medical director. I mean,
There is
we
no such thing.
give a report, so.
There is no such thing as a regional medical director.
I'm sorry.
There is a chair of a REMAC. There's no such thing as a regional medical director unless the body decides to make that a position.
We have that.
We have that.
Yeah.
It's
Dr.
reading.
Fisher.
We've had that right along.
And do you have a job description for that?
We've had that right
We would
along.
love to see that.
In the protocol book.
Right.
Dr. Fisher is our regional manager.
As Gus goes, not me, is our regional medical director.
So I think it's a good time, in the context of RSI, to blow it up to maybe a bigger review of what are we doing in the region for QI, because the Article 30 stuff is pretty specific. Every agency shall participate, and
Right.
I recall that agencies were kind of teaming up at the county level, and there was sort of county level QI functionality.
I think that more and more responsibility is being, and correctly so, being put back upon the agencies themselves on the statewide level. And I feel that this is the way for us to go also. I mean, we're looking at summaries that the agencies advise us of. For example, if the agency once a year sends me a list and says the following folks have taken care of their procedures for the whole year, and they're fully qualified to continue practicing as credentialed techs. Well, I take their word for it. It's signed by the chief operating officer, and it's signed by the medical director.
But in terms of say we're gonna review intubations regardless of how you get there. Theoretically now, the region, i.e. you, could pull that data and
Right.
with a, you know, a template for a quality review.
Sure.
And there could be sort of centralized quality oversight for the region, is that right?
Right. I can pull that information right off the state bridge. When it's working properly, I can pull it right off the state bridge and agency by agency, if need be, or, you know, cumulatively.
So I guess the question is, so who looks at that, determines what's gonna be audited, how it's gonna be audited, and then who gives a thumbs up or thumbs down if there's any outliers or kudos deserved?
Some of that would be subject to REMAC purview, right?
Could be, you know, I think Tom's got a good point. We don't have an infrastructure for it now, or we lost it.
Okay.
Mary and Joe would definitely know better, but I think if I remember correctly, QI is responsible at the agency and the region level and not in between unless it's subcontracted sort of out.
Every agency has to have a QI plan, but additionally, it's one of the deliverables under the REMAC, REMSCO program agency, pick whatever. I don't know which one it's specifically listed under.
Like I said, she said so much better than me.
So I think,
The other part of that is I think that even with the state bridge, well, you know, the thought process, and Dean, you can correct me if I'm wrong, not every agency, you can't really determine, you can put, I guess, filter it out based off of certain things, but you just get an intubation report. You don't know necessarily that that intubation is an MFI or a regular intubation. Unless you put in some other qualifier such as, you know, succinylcholine or etomidate.
So in the version 2 of the Nepsis data that we get, those medications are not always specifically listed or not specifically listed in the same way. So pulling the data at this point is not realistic. In the version 3 will be much easier, but you'd have to pull intubation. The criteria would have to include intubation and one of these 3 medicines. And that would indicate and so I actually, because you guys were going to be doing this, I actually tried to pull data to send you, and to be frank, it's hard to pull that data because not everybody's charting in the same way. And the Nepsis 3 version, that'll streamline that to make it better. But to get the data, you can pull out, like, I want to know everything for a particular agency, you can pull that data. Everything for a particular medication, if it's charted properly, you can pull it. But you're going to miss probably half of them because some people put it in their narrative, gave this medicine at this dose.
I think that's what Peter Brody did when he put together the document I was talking about earlier. I only took a quick look at that report, and like I said, I was not able to print it out yesterday, but I think he plugged in some filters, some medication filters.
Right.
Along with the intubation.
Phil, Peter and I were talking, and he's made the offer, if you ask him, he can come out here and explain a lot of this to the docs and whomever.
Oh, that's wonderful.
You just have to ask him,
Okay,
and he'll be happy to come out.
okay.
Dean, another thing with the qualifier is like that, if there was more than one agency there, and they all document on their PCR that MFI was done, and they just put what agency did it, isn't the state gonna see that 3 times, or 2 times, or?
Okay, so I will answer that question from the lens of Remo, okay? So that's my disclaimer. If you are the agency that is performing the procedure, MFI, RSI, whatever you want to call it, then you are the agency who should be documenting it. So if you are the ALS fly car system, and there is a BLS transporting system, or any other agency, if they didn't do it, they should not be documenting that on their chart. It should be on the chart of the agency that did that procedure. Otherwise, it will go in twice. It can be recognized
Well,
twice.
this was a topic of even Narcan administration. Peter Brody and I had a conversation here because he couldn't filter out. I mean, we were involved with this time in the city with Amsterdam Fire, which they document it. If we have a medic on there, they document it as well. With EMS charts, it's a little bit different because now you have different pages that document procedures done by someone else. But that was an issue, is getting that information because it showed double.
well, what are we, you know, since you're already in the midst of the Peter Brody designed RSI analysis, pulling data. What period is that for? What period is he reviewing?
I believe he did for just this year to date.
This year to date?
Hmm.
All right, well, I think we could take a look at that and see what's doable
Sure.
in the current data stream. And from that, maybe think about other audits that we've done in the past or want
I'll,
to do.
when I get back today to the office, I'll check and see if the report writer is being friendly, and if it isn't, I'll give Peter a call, and he can get in there and massage it also.
Okay, sounds good. Any other comments about RSI, QI? All right.
So all the feedback goes to Joyce?
About her proposal? Yeah. so
Well, the
I think-
RSI, yes, she would very much like to, you can send it to the AAREMS address.
Okay. Some concerns, 1 tube a quarter, requalify?
I'm sorry,
1 tube a quarter was enough to requalify?
I honestly didn't.
I had some concerns.
Okay, well, by all means,
Thank you, sir.
let's hear your suggestions, yes, absolutely.
And she had asked for that by October 1st.
She wanted me to make the point that there's a lot of information there, and it's kind of uncharted territory. So she welcomes what you all have to say about it.
Phil, can I just ask what I intend to be a quick question, but I don't know if it's going to be a quick answer? As a member of the Training Ed Committee, to the physicians in the room, what's your biggest concern about bringing RSI, whatever we're calling it, MFI, into this region? Or do you have concerns?
Yeah, I think the biggest concern, just for that procedure, regardless of who's doing it, is it applied appropriately?
So we're talking
Are we
about-
intubating people who need it to be intubated?
So critical decision-making and appropriate choices for patients. And what's the scariest part of the procedure that's bothering you? Because I'm seeing different things come back, and this, I got about 3 or 4 pages into this, and it's clearly a,
Work on that.
well, yeah, but also it comes from a place of fear instead of other things. So I'm just wondering, because it's going to come back to you guys, what can I bring back to the committee? Are we worried about paralytics
Absolutely.
Yes.
Yeah.
more than anything else?
You're
Well,
taking away
death, we're
somebody's
worried
breathing
about death,
ability.
unnecessary death. as well.
Right, well, yeah, I don't think anybody likes that.
And it's
opposed to necessary
it's not restricted to pre-hospital. Within hospitals, nursing is extremely anxious about all of these agents, because and some of them are new to ED nursing, for example. So you start pushing propofol, and the ED nurses get pretty anxious if they haven't seen it before. And we have to sort of buoy them with education, understand, what the early warning signs are of apnea, hypotension, a few other things, so that it doesn't result in a unnecessary adverse outcome.
The only other
It's
thing
really
I
about
was
adverse outcomes.
looking for feedback is number of calls per agency. I found that interesting. So I didn't know, are you guys worried about calls per agency? Are you worried about real tubes versus training? Are you worried about controlled environment training versus uncontrolled or less controlled field? And I guess my root question is, I don't want to see the Training Ed Committee go through all this work to then have it turned around. So I guess the biggest question is, do we think this skill set, this procedure is necessary for the region? If it is, then we can certainly find a safe, effective way to provide training, ed, oversight, and implementation. But
Howard, can I just say something?
Yeah.
My concern about this region, and it comes based upon the actions of one of your graduates, is someone may recognize the need an RSI, do the skill completely 100% appropriately, but because of a prolonged transport time, cause undue harm because they didn't realize, either A, they didn't realize the need to sedate, or B, in this region, if you take out, like, say, Sydney, GABAC, and a few other agencies that have close proximity to the hospital, most of these guys are facing significant transport times.
right, I would take the same argument and say that in an area where rural health care is provided and you have minimum availability for backup ALS providers, that we need to find a way that when a patient needs to be intubated, they need to be intubated. For me, this is about figuring out when they actually need to be intubated and then making sure that the paramedic providers that are out here have a safe, effective way to do that when the patient needs to be intubated. Because single provider back of ambulance, BVM, OPA, whatever, does not bode well usually for a patient. But I think they should be few and far between. So you're absolutely right, Mary. Look, people are going to make mistakes at every level of healthcare, and
Right.
our job
But I'm
here
just
is to
saying,
try and
the
come
other
up
thing
with
is,
something to
isn't the
minimize those.
NAEMT also looking at the viability of endotracheal intubation pre-hospital?
No, they stopped.
They did stop?
Yep.
But there was enough concern there.
Sure, absolutely.
And that's truly my concern. I think we're opening up a new avenue where my priority is do no harm, and we are opening up an avenue where we can do harm. And I think that skill set's gonna be really important.
Yeah.
And the
My only
the
counter
clinical
argument,
decision-making is gonna be really important.
absolutely, it's paramount. My only counter argument to that is that if the patient truly needs to be intubated, we need to be able to have an avenue to do that. So if we do things like take away nasal intubation and de-emphasize training on that also, that leaves us with our providers without too much of an opportunity to provide definitive airway management when they're in that rural environment and they're up on the top of the hill in Summit and it's an ALS, BLS ambulance with 2 providers and that's it, and there is no somebody else coming to help. So
But then you still can't do the procedure because you need to have 2 MFR
Right.
certified medics,
that's
which
kind
is
of,
never going to happen.
It's not gonna happen in our region.
Nasal intubation's approved.
Well, the one thing Joyce also keyed in that I think is key is experience out in the field. Taking a brand new medic and saying, hey, we're gonna run you through a class here on airways and now you're RSI, MFI. Not happening. Joyce has been very clear about that.
Why not?
I don't necessarily
I
agree with
disagree
that.
with that
Because they don't
statement.
have the experience.
How do they get it?
You learned it in paramedic school.
How
You
do-
learned it in class.
That's not valid.
I think
Well,
there was
That's not
You
valid.
have to have street experience because you have people tubing people that don't need to be tubed RSI'd when you are 5 minutes away from the hospital.
I completely disagree.
So you have to disconnect those.
So,
See, this is a really good
Yes,
topic.
I think what we should probably do is get the REMAC and the Training Ed Committee together for an actual sit-down.
Well, here's the other thing, it's like, so we're operating under like multi-regional protocols, right? So this protocol, the collaborative protocol now extends over most of New York State.
15 of the 18.
And yet we're designing QI oversight education locally. It makes no sense to me.
Dr. Mark, I have a question. Your concern was that the 1 tube a quarter was too little. So in most cases, that's going to be a practice tube. And this is just a question because the larger agencies, and other people can speak on this, the agencies, how many tubes are your lead tuber getters getting in this region a year?
Intubators.
It's in the data.
Yeah.
We need it, that's why we need data. But
Seriously,
back-
I mean,
Tubal ligation.
Well, you're not
Garrett can
getting
see it
the
too.
data, you're not getting it per person. You're not gonna get that data per person.
Yeah, that's right, it doesn't drill all the way down, right?
Right. I don't think you're seeing very, are you getting anyone that has double-digit tubes?
Oh, yeah.
Yeah?
Yeah.
Is CMT getting double-digit
Yep.
tubes? Or anyone other than GAVIC and CMT getting double-digit tubes per provider?
Well, anyways, I think it's, these are all legitimate questions. I think to approach it from, the point of view of do no harm is a good starting place. And that's what we're trying to figure out is like, how can we go forward? What should the policy look like? But more importantly, we spent a lot of time obsessing about protocols and, the permissiveness or lack of permissiveness about protocols. We spend less time, and I'm not talking about just this region, but I think in the state, worrying about the education and the QI, or the oversight of that process. So you put a drug out there, well, how often is it used? Do we know? It's there if they enter the data correctly. So a lot of times we're writing protocols and doing it fairly blindly. We do it on the front end, and everybody walks away, and then if there's an adverse outcome, we scratch our heads and wonder why. But we don't have any infrastructure for the QI process, the outcomes research of, so you did this, what was the outcome of that? So it's a good natural, there's 2 natural experiments in our minutes today. Cherry Valley and Stanford are both dropping ALS. Stanford is dropping an ambulance. it's a natural experiment. You have a zip code there. What happens to those people? So I think some outcomes analysis of the things we're talking about in coupling with the RSIs. I think RSI is a good place to start because it genders a lot of concern and questions about, you know, how often, who, et cetera. So designing that QI, I think, will be a good exercise for everything that might follow in terms of, you know, not obsessing about what the protocol does or even the policy, but so are we confident that we're going to be able to pick out, you know, we've had some outliers, right? We've had some outlier practices identified through the database. So we need to be able to have that ongoing so that we don't get into dangerous territory.
I see something good here, my own twisted thinking. We're finally zeroing in on things we can heartily disagree with, and that's not a bad thing. That's not a bad thing. I think good comes of that.
I think we probably have two easy actionable items, at least out of this meeting, and one is that training ed needs to sit and meet together in the same room with any stakeholders who wants to be interested before we bring this back to the REMAC body. And now we've got some good feedback, and honestly, maybe we even invite the members of the REMAC down to that meeting and we can just kind of hash this out over a few hours.
Yeah, excellent. Yeah.
And I think we can charge the region with the establishment of a regional QI committee.
I would second Howard's thoughts, except have the REMAC meet first and set out what they're looking for.
So that's actually defeatist with the whole purpose of creating a training and ed committee to serve the REMAC. So we were charged by the REMAC to come up with these standards. We just need to come back and present them and then look for feedback.
I see what you're saying. I'm going under, we work for them.
Right. And the training and ed committee is a subcommittee of the REMAC, and if the REMAC wants to do that, they can go forth and put through stuff, but it makes no sense for us to go back and forth.
What goes on in REMO? Does REMO have like an annual airway education update kind of thing?
So we do, and we have morphed things. This is morphed, and so I'm going to offer you a couple of glimpses from the experience. So REMO was at this exact same point at one point, and so we went forward with it, and then we went really low tech and designed an airway. Really, it's an RSI-MFI audit tool. And the agencies were awesome at making sure that a tool was done and faxed to the office within 24 hours. And we saw very little negative effect. Very, very few times we had a negative effect. Almost, I don't think you could count on one hand the number of times we had a problem. So we did that for years and years. We've kind of gone by the wayside of doing that now because the agencies are really excellent at monitoring their own thing because they all know they own this liability, and the medical directors are super involved with that. And so the problem is really just not as significant. I shouldn't say significant. The problem that you are worried about, I don't think you are going to experience. And it's absolutely due diligence to be afraid of these things, but in hindsight, flawless.
Okay, so yeah, so it may be a concern that if we talk about the whole region, it seems kind of daunting. But if you localize it to the agencies that are doing it day in, day out, less daunting, with an identified medical oversight structure for that.
In fact, REMAC is more concerned about the agencies that are not MFI credentialed.
You're right.
Trying to fake it with etomidate.
Or morphine and Versed.
Or morphine and Versed. That is the biggest concern, is that the agencies that are not MFI credentialed doing it half of the way and still trying to get the two.
Didn't 3 months ago we talked about this though and said that REMO and AAREMS were not really comparable as far as MFI statistics go because you can't swing a dead cat in REMO without hitting a hospital?
So, you know what, that is true. The population in the hospitals are different. But there are some very rural places in REMO that have MFI, and they're successfully doing that. And so if you look at those, they're having the same effect, the same result as the places that are in the cities.
Greene County is an excellent example of that.
Yeah, Greene County has an awesome program. Religiously send me those forms, and they don't have problems. And you know, if you look at just Greene County or take the opposite extreme, really rural Rensselaer County, okay, right? They're polar extremes. No problems up there either. So I think that I think that the system will work through itself. If you let the agencies manage this with the medical directors, I think you're going to be safe.
Does Remo credential the providers?
Remo at the beginning did credential the providers, and technically, I say Remo, we had a credentialing process that was forced on the agencies. Would that be the right word? That the agency was obligated to do this training program and credential them in this particular manner. We have kind of gone away from that, and the agencies have morphed it to fit their system.
With minimum standards from the region.
Right.
But the agency's credentialing.
The agency, because it falls on the agency medical director, it does not fall on the region.
So it goes back to that same, if you're credentialed in Greene County, you're not credentialed in Rensselaer, you have to do it again in Rensselaer County.
And it's not by county, it's by agency. So
Well,
if you're
I'm just-
credentialed for GAVAC,
putting
you're
out
not
an
credentialed
example.
for CMT.
Right.
Right.
It allows medical directors to truly manage their own fears, risks, etc. Whereas, if I worked for Dr. Markowitz, he could say, no way, we're not doing that, or no way, you're not doing that. If I worked for Dr. Leinhart, he'd be like, sure.
Accommodate for everybody.
So it's literally.
Right,
two
accommodate
different-
for everybody.
What we're looking at is two extremes, the Monroe-Livingston extreme where they control everything through the REMAC at the regional council. And we're hearing Remo saying, hey, medical directors, it's on you. Is that a good
Legally,
summation?
that's where it lies.
It is where it
And that actually happened in Remo back when this came out, actually, in the late 90s, early 2000s, when the REMAC turned around and went, hey, yeah, no, this is individual medical director issues, not a board that meets a few times a year.
See, we used to be wise. Okay,
Dean, could you share that audit tool with me?
Oh, sure, absolutely.
We had an airway form here that was, in fact, I think we got it from Remo, and it labeled it right on him, and it was being done on every intubation.
The nice thing with that is that
It is.
the audit tool requires
Yeah.
the physician to sign off at the hospital.
all right, Grand Gorge seeks, I guess, provisional approval for ALS status pending.
They're already responding ALS.
They are?
Yeah, I believe we did provisional at the last meeting, and they've gotten their stuff since then.
Yeah, what happened was Gus, I polled the doctors by email on July 25th. We had a majority of the REMAC docs approve Grand Gorge provisionally, so this is just a formalization of that.
Oh, okay, so there's no action required, it's just informational.
Just that everybody is still in agreement.
Okay.
Mary, did Grand Gorge put in their paperwork for their,
I believe so, yes.
they did, okay. So then,
Actually, I think they have their license already.
They have their
I believe they do.
Yeah.
do they have?
Responded already.
Okay.
All right, so that's the end of the listed agenda items. Any other business?
Actually, Gus, Phil might want to bring up with Dr. Fisher, there's issues popping up all over the place. I guess there's been a couple of hospital pharmacy changes, and their agencies are having difficulty getting drugs in general, and more specifically narcotics.
Right, we are experiencing, I say we, the speculative ambulance, which is a license for controlled substances, has been for 19 years. With the new pharmacy director down there, we're having some difficulty. Mike Tracy can talk to this. There's a kind of a catch-22. We can go down and get controlled substances, but we have to have an official vehicle. We can't take our own vehicle to do it, as per federal law. So Mike is right down there with a fly car. He's a member of our squad. He's right down there with a fly car from Fulton County. So I'll let you pick up the tab on. I sent a whole bunch of paperwork down with Mike.
Yeah, it was mostly outdates to restock, and I brought it down to the pharmacy, and I went on vacation, and I came back from vacation and the pharmacist told me that the director had to review it. So I told Phil that, and I gave it another week, and I went down again, same answer. The director had to review it. And now I think we're going on probably 6 weeks now.
Right.
That we've been unable to get them.
Right, which leaves speculative ambulance without any controlled substances because our outdates are down there, our restocks are waiting to be filled. Now, back in April, when the new pharmacy director took over at Nathan Tour, I sent him a hard copy of our protocols. I sent him a copy of the REMAC decisions on formularies, formulary minimum numbers to be carried, etc. I sent him a copy of the controlled substance operational plan that the speculator and a number of other agencies worked under. And when Mike came back and told me originally that the pharmacy director, quote unquote, had to review this, I picked up the phone, I called the pharmacy director, left a voicemail with him, called his secretary, left a voicemail with her. To this date, since April, I've heard nothing from the pharmacy director or his secretary or any of his staff. Nothing, whether regional or the speculator ambulance.
Do you have any kind of a contractual agreement with that?
Oh, sure, that's part of the controlled substance plan. Yeah,
So it
if
sounds
the
like-
hospital agrees to provide the controlled substance.
So then you need to elevate it above the pharmacy medical director. He has a boss.
Right.
Well, we just talked about this, and I'll speak with the pharmacy director, and it will be straightened out. I mean,
It's not only controlled substances. The other night, and Jack certainly can speak to this, there's ambulance services that are functioning under the new protocols that don't even have the medications that are in the protocols. Like Northampton can't get Decadron from them. Now, they can get it certainly somewhere else,
Right.
and probably should.
And we did, but
This
we've
is-
always gotten our medications from Naval Tour Hospital Pharmacy.
I think Decadron might be a problem, because there might be a shortage of that in the hospital. In fact, I'm pretty sure that there is.
But
They
I
could
think
tell
that we
us.
still should have to
You know,
Right.
explore
Well,
other
I
options.
redid the rec form for the new protocols and everything, and he has not acknowledged a thing.
So I'll speak with him, maybe with Phil or with someone from up there, and we can straighten it. He'll respond to me.
All right, any other business?
A little bit under that, on the last REMAC meeting, we approved, some minimums were approved for medications in the formulary. There was a couple things I wanted to ask. Metoprolol, we're saying they have to carry a minimum of 4. Can we lower that down a little bit? Maybe 2? Any other agencies pushing ever 20 of metoprolol on a run? Or back-to-back runs? It's not even in a first-line drug, it's only physician's option.
I don't see your problem. Why wouldn't they be able to lower it down to 2?
3 is your AHA recommended dose.
But it's the problem is,
I'm okay with
we are creating part of this problem with agencies failing. We're putting, every agency should know, based off of transport times and things like that, what they should have in order to provide a service. These medications are sitting in our bags, in rotting, you know, and expiring, and we're just throwing them away. It's a physician option. It's not even a standing order. You know, no different. You know, glucagons. I mean, really, they're going to waste at $165 a piece. This is no different than the EpiPen stuff.
I completely agree. The only thought that I'll offer is that if you drop below required meds to complete ACLS, that you should be careful because you're no longer able to provide the care.
And I remember glucagon being dropped to 1 at one point, so I'm not sure where it went back up to 2.
So like low pressure, I think would be 3.
Yeah.
But
And now
yeah,
we've got glucagon at
I
2.
agree. When was the last time here anybody pushed calcium chloride?
We do it
I
wrong.
think in 20 years.
Oh, dialysis center. Cheater. Now you know where to send your expiring calcium chloride.
It melts ice on the sidewalks too.
Specifically, it was metoprolol. Even if you want to go from 4 to 3, that's fine. The glucagon was the other one. And I had a question on remazicon. Should we be carrying remazicon as a reversal for the benzos?
That's a protocol committee question.
There's an ongoing question.
Active agency, the SBA determined if I carry an
It was
IO,
out.
why do I need glucagon? Like,
Cause a seizure.
Seizure.
Cause a seizure, you have to be more versed.
as long as you have limbs.
And they did take it out.
So if you give it too much romance, it's not real, you can say that.
It would just be us that approves the reduction, or is that going anywhere else?
You guys are the ones who put the reduction out in the May 18th, or put the minimums out in the May 18th meeting, that's why.
It's up to the REMAC to set the levels.
I say, I'd be going down to 2 would be fine. I really don't see a reason why they would have to carry that many if they're not using it and they're just wasting it. It doesn't make a difference to me at all.
Yeah, so yeah, I agree.
I think a friendly suggestion.
I think it's another use of the data, right? If we had medication and we see that calcium chloride is out there and never being used and rotting, along with a few other drugs, we could probably whittle down the formula based on actual utilization.
You can't take stuff off the formulary without it going through the CMAC.
Right.
You can change the minimums.
Because it's wedded to the protocol, is that, because it's embedded
Yes.
in the protocol,
The
right?
protocols are part of, and these protocols were written specifically to allow the regions variation, because each region could determine their PAR levels,
Right, but not the
but not the
inclusion.
elimination thereof.
Right.
Or addition.
But I don't think nobody mentioned removing toprolol or calcium chloride entirely, right? We're talking about reducing the amount of the carriers.
You can carry more than the minimum.
You can always carry, the minimum in Narcan's 2, I'm carrying way more than that.
$5 gallon bucket.
Pumpkin spice.
Pumpkin spice Narcan.
All right, so I don't think there's any physician opposition to reducing the PAR levels of, of metoprolol down to 3. And what was the other?
2.
drug?
Glucagon down to 1.
Glucagon down to 1, metoprolol down to 3, so that Howard is happy that we can comply with the American Heart Association ACLS guideline.
Glucagon down to 1, calcium chloride down to 1. You can always carry more if you want to.
Yeah, we think that's fine.
A lot of intercepts.
Always carry more.
The other one was the Decadron. In the meeting before the May 18th meeting, it's written in the protocol that total per unit of 4 milligrams. We're getting them in 10 milligrams. And I think that we'd said as long as there was 20 milligrams on board that you guys were fine with it. In the print-up that Phil sent out with the meeting minutes, it says 4 milligrams, 5 doses. Well, if it's 10 milligrams, are we okay with 2 doses? Because either way, it's only 2 doses. Right. It was just kind of weird on the sheet that was included, and I think Phil was putting it on the website.
Tennis protocol.
They put it in place of some Medroll. Just not like. Yeah. Not at all.
All right, any other discussion, comments?
So what was metoprolol to 3, glucagon to 1, calcium chloride to 1, and Decadron a total of 20 milligrams?
A suggestion that it's.
Decadron and Solumedrol in the protocol are what, interchangeable?
No,
Solumedrol's
Solumedrol's out, Decadron's in.
The dose is 10 milligrams.
That's a lot.
That's
That's the way it comes.
That's the dose in the protocol is 10 milligrams.
That's fine. Yeah, the physicians think it's okay.
The dose is 10 milligrams also.
Absolutely.
Yeah.
There's multiple concentrations, but
Right,
as long
multiple
as you carry
concentrations, but
20
the dose-
milligrams and dose 10 milligrams according to protocol, you're okay as far as I'm concerned.
All right, any other questions?
Cardisan.
Cardisan, great drug.
It is, have a minimum of 3. There's a lot of places that can't get the reconstituted and it has to do the refrigerated and we're throwing away every 30 days.
Three vials of 20 milligrams or something,
3 25 milligrams.
You need
75.
all 3.
Last protocol was on 25.
yeah, it sounds like a lot, it's a lot.
The last set of protocols, it was knocked down to 1.
Yep, so you already have. permission to go down to one, it sounds like.
Well, no, the protocol previous, it went from 1 to 3 somehow.
So you jump back up to 3.
Again, because it's a weight-based drug, and you can't treat people
I vote for 9.
with. Tony?
Yes.
The reason for that is because it's a weight-based drug, and if you went around this room, there's only maybe 3 or 4 of us that would actually have enough in one vial.
Okay.
I vote for you use us.
I include myself.
In 2011, it was 1. In 17, it went to 3. Are we good with 2? Would I need more than 2, Howard?
Dude, when you show, you tell me, it's 0.25 makes per kg.
It sounds like a lot to me. I give very large people 20 milligrams, and they do fine.
So, right, so clinically, I agree wholeheartedly. I went round and round with the protocol committee on this, and they refused to change the dosing because the Heart Association still sticks to the 0.25 mg per kg, and then a repeat dose. The agency I work for dropped it to 1 because of a perceived cost issue, and I ended up being the guy who's in the back of an ambulance trying to redose somebody, calling for another paramedic to intercept me, and then having an awkward physician consult going, hey, so I don't carry enough to do this, they're kind of stable, do you want amiodarone or electricity or just sit and wait? So,
Howard, in the
yeah, lots of glucagon, calcium chloride.
Oh, they just put that level
What's
down.
expiring?
hey Howard, in the new protocol, it's a max dose of 25 milligrams.
Correct. On orders.
Right.
Right.
So we're cute. 2?
Whatever you want, just treat me if I get sick, that's all.
I'm personally fine to go down to 1. If you want to keep it at 2, I'm fine with that too. I think 3
What's the
sounds
cost
like a
on it,
whole
Tony?
lot to me.
It's dirt cheap.
Yeah, that's my point.
$13 for a box of 12.
Right, so
Not expensive.
I think if you're looking to save money, buy IOs and ditch glucagon totally.
I agree.
Or get your IV.
Yeah, but glucagon is an overdose.
Yeah.
You can.
Not for us anymore. It's not in our protocols anymore.
Right.
Isn't it a physician option?
Nope.
They took it out.
Yeah.
All right, any other comments, additions, deletions?
Who's decided?
What was
Two?
decided on partisan?
Yeah, I do need some more.
Yeah.
We're talking about vials of 20, that we're talking about.
I don't care, I just want the number.
Save $75.
2.
Two?
All in favor for 2?